And the last speaker for this session, may I invite Professor Tim Poleman, the president of the AO Foundation and my great teacher, to talk about the geriatric acetabulum fracture, leave it, fix it, or replace it. Dear Professor.
Thank you very much for the introduction. And this is a topic, leave it, fix it, or replace it. I have to share a secret with you. Before I started doing pelvic and acetabular surgery, I was very much in total joints. And all over my career, I was doing total joints, so I can see it from both worlds. So basically, the question is whether the increased use of total joints for fracture care in geriatric acetabulum is really a hype or a trend, or whether we have a common ground where we can decide which fractures or which patients are best treated with a reconstruction and others with an immediate replacement. So the only trend which is absolutely true, this is demographics. It's an aging society, and every country, in the world somehow goes over the stages, and Germany is now in a status that we have many elderly patients. Does this reflect in studies? Certainly yes. So we have this study, Samir Mehta and Jamie Ann published this Medicare data, and these show that over 17 years, 600 million hospital treatments, proximal femoral fractures are going down in incidence, whereas geriatric acetabular fractures are going up. And we only can speculate about the reasons, but certainly the activity level is higher in geriatric patients today. And we know that we need fairly good bone structure to get an acetabular fracture. So if the femoral neck is so weak that it breaks first, but if somebody is more active, we have more of those fractures. Does this reflect in literature? And we have to go a little bit into literature. Not really. Over the last 35 years, in the beginning, we only had one paper about primary total joints. There was a peak in the 14, but there were never more than 5 to maximum 8 papers a year about this topic. And it's quite divergent what we have here. It's a German study, and the conclusion was, total hip replacement, no reconstruction if we have a complex fracture. So the problem is already, about the judgment of the fracture, whether there was a right classification done. And in their hands, only 30% of the reconstruction showed some acceptable results. If we come to the combination of stabilization plus immediate replacement, so this is a Rickman study, we have to keep in mind that this is major surgery. So they had up to 280 minutes of operation time and a blood loss with 2.5 liters, which certainly is not something we should offer geriatric patients as a routine. This Chinese group reconstruction has good results. So excellent results in relation to quality of reduction, fractures of the posterior wall and femoral head injuries, same indicators we have in young patients. Hip replacement, so Ann Sermon did this study, whether it's better to do it early or after healing. And she found out that the primary total hip replacement after the fracture had worse result compared to a secondary post-traumatic arthrosis type. But also this is not very easy, and this is Dan Barry, and he said there are specific problems if we have to do total joints in post-traumatic situations. So pros and cons in all sides. This was a recommendation that immediate total hip replacement should be done in selected cases, massive osteoporosis being one, combined acetabulum and femoral neck, and pathological fractures. So not really helpful in the regular fractures what we see. And here, in this case, we have a meta-analysis, including some of the studies we already discussed. And this is always a problem with the meta-analysis. They have a higher evidence level, but on the other hand, they are based on the studies individually we cannot really use. So overall complication rate, not too high with 13%. The secondary hip dislocation after the total joint was the most frequent cause of revision, and the Harris hip score was fairly good with 82. So the conclusion was the stabilization plus total hip is safe with an acceptable complication rate. What's the outcome after reconstruction? So 1 year mortality, 25%, comparable to the other proximal femoral fractures. Conversion rate to total hips, only 28%, in average 2.5 years after the operation. And this comes, to the gold standard of results we have in young patients. Is there another trend? And this is a meta-study from Germany, from the multi-center study group. Here, the colleagues are working on minimal invasive offerings, to reduce the trauma for the geriatric patients. Still, the reduction being open and needs more attendance. Coming to the standards, Letournel said in 93 in the last edition, age over 60 years, insufficient bone quality, this is a contraindication for operation. And basically the result can be sorted out with controllable factors. This is what we can do, what we can achieve, and uncontrollable, age being one of the major ones. What is the gold standard? Still with a 20% conversion rate, Letournel series and Matter series are the gold standard. And this is a Tanast paper where the Matter 810 cases were analyzed. Negative predictors also here, age over 40 years. Otherwise, it's a quality of reduction and some specific involvements. In our hands, German numbers, 40% over 60, contraindications from Letournel. But we also did a study on the long-term result of acetabulum fractures, even in these multi-center hands with many surgeons only having a limited caseload, we basically can create the same results than the gold series. So we have a 20% conversion rate, 80% survival rate over 15 years. And what we can see here, that after 2 years, basically we can expect a surviving hip after reconstruction. So this is something which allows us to translate the results of single surgeons, very specialized series, into the multi-surgeon, multi-center offerings to our patients. If we're coming to the reconstruction, basically we have specific fracture types for geriatric patients, and this is anterior wall, anterior column, posterior wall, now being the majority, sometimes both column. If we come to the dynamics, this is a typical fracture pattern. But if we do the standard fixation, which is usually proximal to the acetabulum with leg screws between the anterior and posterior column, we have a situation that in the fairly soft bone, the regular implants will loosen out and the construct will not be stable. So the logical way would be that we can combine and statically fix the posterior column proximal and distal to the acetabulum. Many studies were done to increase its fixation, to address the quadrilateral plate. Also, we published on this. But basically, only the combination of a plate to the anterior column and rigid fixation to the posterior column gave sufficient stability, and also is the cheapest solution. So we published on this, and basically this configuration ensures that the horseshoe of the acetabulum cannot open up, and then the head cannot protrude. The quadrilateral plate does not really matter, because if the posterior column goes out, then the head will also protrude, because you cannot really keep the quadrilateral plate stable. Basically, there's only one addition now. This is from the AO, from the TK. This is a specific design where we can put a leg screw into the posterior column. So this overcomes the problem, that we do not really have a stable fixation to the posterior column. Based on our results, we are now proposing following patient-specific algorithm. And this comes to patient status, surgical ability, so what we can perform, and the prognostic parameter. So basically, if everything is fine, like in this 89-year-old patient, standard ilioinguinal approach and reconstruction, we do the patient here walking on post-op day 3, and after 2 years, now 91 years, completely rehabilitated, still active, so no difference to young patients. If prognostic parameters are going down and the patient status is not as good, we might go for a limited approach because we want to get the joint to a healing in preparation for a secondary total hip. So this is only first window, short operation, reducing the anterior column. We saw the patient again after 1 year with a trochanteric tip fracture on the other side, but the hip survived. So minimal effort, maximum result. But there are bad prognostic parameter, and they will lead to immediate replacement. Posterior fracture types, posterior wall. So even old patients have motor vehicle accidents. So what we see here, that's a dislocation. It's a multifragment here, posterior wall. It's a multi-trauma, polytrauma patient. So here the head was used as a replacement for the posterior wall and combined stabilization and total joint. So we see the patient walking here, does not want to walk. So, but you can imagine. Another situation like this, 86 years old, multimorbidity, disabling pain. We see this is a head destroyment, so there's no way for reconstructing this. And with a specific augmentation cup, this can be solved. Another patient like this, secondary transfer after 4 weeks. Also here with a good planning, immediate replacement of the hip. There are some situations where the standard implants or even the enhanced revision implants do not help. So this is something where patient-adapted specific implants, manufactured implants, can help in the future, like in major revision surgery. So this patient wants to walk, so this is the solution. In summary, the increase of these fractures is a serious trend. So we have to find strategies to overcome this. The trend towards now shifting completely to total hip replacement is not clear to me, as we still have 80% good and excellent result in reconstructing the hip in this specific fracture pattern we will see in those patients. So this is certainly something that only in selected cases we will go to very early or even immediate joint replacement, and the risk factors being osteoporosis, combined acetabulum femoral neck, femoral head fractures, and atypical, specifically posterior fracture types. But we have to keep in mind, one stage replacement plus fixation is major surgery for these geriatric patients. Thank you very much.